Hello, everyone. Here with me today is, makes no introduction. You've seen her all the time during WHO press briefings, Dr. Maria van Kerkhove, who is the technical lead on COVID 19 at the World Health Organization. Maria, thank you so much for joining us today.
Thank you so much for having me.
Well, WHO has been reminding everyone really that this COVID 19 pandemic is not yet over, right? But being here in Geneva, you're seeing things feels back to more to normal, and it's not just in Geneva and in a lot of countries. And also COVAX is saying there's been a slowing down of demand for COVID vaccines. I just want to get a sense, how concerned are you with all of these developments in the response to COVID-19? Or are we seeing the end of this global emergency?
So, first of all, thanks for still talking about COVID-19 because it isn't over, unfortunately. We're still very much dealing with this virus that is circulating at an incredibly intense level around the world. We're in a different phase of the pandemic for sure. We have an incredible number of tools, life saving tools, that if we can actually get to people, will save their lives. Having tools for tools' sake, but not actually using them won't help people. So what we are seeing across the world is we're seeing a significant decline in people needing hospitalization and people dying from infection from SARS-CoV-2. And that's a good thing. That's what one would expect when you have so many safe and effective vaccines. But that decline in morbidity, mortality, burden is not being seen everywhere. And the reason for that is because we don't have these tools, these vaccines in every country. So what we're trying to do is ensure that in all countries we reach this 70% target. But within that 70% target of all populations, it's 100% of at-risk people. So people who are over the age of 60, people who have underlying conditions, and we will continue to fight for that because we know it saves people's lives. It's not only the morally right thing to do, but it's the epidemiologic right thing to do. And it's also the economically right thing to do. So we're still dealing with this virus. And then we can't say it's over yet for the sheer fact that there are at least 10,000 people dying every week, most of which are preventable. And this pandemic has changed our entire life. It's either it's someone we know we've been infected ourselves, or someone in our family has died, but it's changed futures. It's changed people's trajectories of where they're going in their life. So there's a lot more that we need to do to end this. So unfortunately, it's not over. But the good news is that we have the tools to end it.
You mentioned about the 10,000 deaths a week. How reliable is are those numbers now? Because we know that several countries have dropped their testing.
So that's a good question. So we are currently monitoring a number of different parameters with this pandemic. We're looking at case reports, like how many cases are being detected each week, how many deaths are being reported each week. And ideally, what we would like to be able to report on is how many people are requiring hospitalization, how many people are requiring admission to an intensive care unit, how many people need to go on ventilation. That would actually be a better marker, but we don't have that data in all countries. Testing rates have plummeted. In recent weeks. So following the Omicron wave, and as you know, I hope we can talk a little bit about the variants, but as you know, many countries went through a substantial wave of Omicron. And those numbers are declining in the number of countries, but testing rates have dropped. So I have very little confidence in the actual case reports. On the death side, that's a little bit different because obviously somebody will need hospitalization and people are dying, and that's easier to record. But we know that both cases and deaths are an underestimate of the true number of cases and deaths. To date, more than 6.2 million cases have died. 6.2 million people have died. Mothers, fathers, brothers, sisters, kids. But we know that the true estimate is at least double that. So we've known from the beginning that we're not able to capture all of these cases and deaths, but it's really our responsibility to ensure that we do everything we can to prevent any further deaths, and we can do that.
Well, people are saying, of experts are talking, it's not gonna go away. Yeah, it can turn into an endemic disease, but it's not gonna go away. But how can we move to like ending the emergency phase? Like WHO has announced a public health emergency of international concern. How can we finally say, no, it's no longer a global health emergency?
So this is really such an excellent question, because as the World Health Organization, we work with everyone everywhere, and we're a global agency. We have regional offices and country offices, but we look at everything as a whole. And we look at this event, this pandemic, as a global event. Now, in individual countries, they may be at a place where their emergency is over, in that sense, where they are managing COVID-19. And when I say managing COVID-19, I mean they have, number one, they have access to vaccines, they have access to tests, they have access to therapeutics, and they're using those to keep people alive and preventing people from developing severe disease and death. But that's not being seen in every country. And so we are not able to end this public health emergency of international concern until we reach the point where we can end the emergency everywhere else. The other concern that we have is that this virus is still circulating at an incredibly intense level. Last week alone, there were almost 4 million cases reported. 4 million cases. And that's in the context of significant declines in testing. So there's a lot of circulation. And with a lot of circulation, even though that's not translating to high numbers of hospitalizations and deaths, the virus still has an opportunity to change. And we don't know exactly how the virus will mutate. So we think in scenarios. We think certainly the virus will continue to evolve, because that's what viruses do. But the next variant of concern we expect will be more transmissible, because it will need to replace other variants, Omicron and the sublineages that are circulating. But we don't know if it will be more severe or less severe. And we don't know if further variants will have properties of immune escape, which means our vaccines may be less effective. So we have to just kind of keep up this level of vigilance. And it's not to scare anybody, but we have tools. We've put systems in place, public health systems in place for surveillance, for testing with a strong workforce. We have adequate personal protective equipment, not everywhere, but we have supply. We have adequate numbers of vaccines. We've had almost 12 billion doses of vaccines administered to date. But about 1 billion eligible people in the world, primarily in low-income countries, have not received a single dose. So what are we waiting for to address this? We've got the supply. We understand how horrible COVID-19 has been. What are we waiting for?
You talked about vaccines, and I also want to talk about treatments, because now that's what everyone's talking about, right? With vaccines, we've had challenges really with equitable access, and now the same narrative is happening with treatments. I just want to get a sense of, because WHO has called Pfizer's the antiviral drug Paxlovid the best therapeutic choice for high risk patients to date. But you're worried about accessibility, and so what is the status of access to the drug in lower income countries, and what needs to happen to change that?
So it's similar to what we are seeing with access to vaccines. I mean, it's wonderful. First and foremost, it's fantastic that we have more therapeutics for COVID-19 patients. In the beginning, the focus was really on therapeutics for severe patients, but now we have antivirals where you can administer them if they're within a certain number of days of developing symptoms. And it can prevent people from developing severe disease and going on to dying. And that's incredible, but you have to have access to it. So we're working on access, we're working on price, and when we say access, it's about production, but it's also about the ability of countries to be able to purchase this and have in country and use. The other issue is whether or not countries are in a good position to have a test that's reliable to get that patient into that clinical care pathway. So as the World Health Organization, we're working on all of those aspects of that, from everything from evaluating the evidence to issuing the guidance to making sure that we have good tests that are out there and getting patients into the clinical care pathway so that they can use these life-saving tools.
One thing, because there's a lot of talk about financing, WHO financing at this week's WHA. And there were some historic decisions that happened yesterday. But I wanted to talk about specifically about the health emergencies program of WHO. Do you have enough funding to be able to, implement all of the things that you needed to do? Because it's not just COVID.
I mean, the short answer to that is, of course, the responsibilities of the WHO Health Emergencies Program, led by Dr. Mike Ryan, our executive director, who's just absolutely incredible person, incredible scientist, incredible leader. No, we certainly don't have enough money to carry out all of the actions because we deal with everything from the COVID-19 pandemic. And of course, we're working across WHO. We're working with many, many partners. The situation in Ukraine, the situation in Afghanistan with monkeypox, with preparedness activities for arboviruses. So the whole spectrum. We don't yet have enough funds, and I don't know how we
How much? How
ever
much is
will.
the shortfall at the
Well, what I
moment?
can say is we have issued an update to our strategic preparedness, readiness, and response plan for COVID 19. And this is essentially the plan to end the emergency of COVID 19 all over the world. And we're about $1 billion short of funding that for 2022.
So what's the impact of that on the ground and also on your capacity within the program?
Well, it impacts everything because when we receive funding at the World Health Organization, that money doesn't sit here in Geneva, for us here. We get that money out to our regions, to our countries to implement the plans to ensure that, when we issue this guidance around clinical treatment or on infection prevention and control or on vaccine delivery, that we are able to support countries, national governments, and partners to be able to implement. A vaccine doesn't save someone's life, vaccination does. And so, as WHO, the people that we are, that we have around 7,000 people that work for WHO, we also work with partners all over the world. And those funds help us actually implement, turn that know how into how to and into action. So it limits our ability to be able to do that.
You know, we've heard, recently disease outbreaks, right? There's the severe viral hepatitis of unknown origin affecting children.
Mm-hmm.
There's monkeypox.
Mm-hmm.
How are you sort of dividing that work within the program?
Well,
Within the
we have amazing staff. I mean, I always get the question. People say to me, Maria, how big is your team? And I have an amazing team here at WHO. And I'm so grateful for my WHO colleagues here in HQ and in the regions and in countries. But we also work with academics and public health professionals all over the world. So what I consider my team, and I don't mean this as a joke, but thousands of people around the world to work with us to help us understand each one of these examples that you brought forward. What is happening with this acute hepatitis of unknown origin? What are the studies that need to be done? How do we expand surveillance? The same thing for monkeypox. How do we advance our understanding on monkeypox, a virus that has been around for years, for decades, to be able to better understand it, to be able to better control it in endemic countries. And now we're seeing different transmission patterns in non-endemic countries. So we work with people all over the world to implement. WHO is a secretariat of 194 member states. So we work with people in countries to implement these programs. So by extension, we're all WHO.
But um, because we're seeing all of this, does that mean that, hey, countries have improved surveillance, or does that mean that we should be concerned because we're becoming more vulnerable to these disease threats?
That's also a good question because it's both. Our surveillance capacities we've been trying to improve surveillance capacities for different types of pathogens, respiratory pathogens, influenza, coronaviruses. In the last 2 years, PCR capacity has expanded dramatically around the world. The use of self-testing has increased. Our awareness of some of these pathogens has improved. And so we are able to detect things quicker. But at the same time, we've really changed the disease ecosystem of this planet in the last 2.5 years because we had a virus that emerged into the human population, completely susceptible global population. The world shut down for a couple of years. And now we're starting to mix again. We're now starting to see different patterns of influenza outside of normal, typical seasonal patterns. Same thing with RSV. We're now able, to see some things that are popping up that were not expected, like this acute hepatitis in children. So we just have to be prepared, and we have to use those systems. We're hoping that this horrible situation that we've gone through, that we're still going through, that many are still going through for COVID-19, builds a foundation that we start from for the next. What we don't want to see are the dismantling of systems and we go back in time. I'm not going backwards. You shouldn't go backwards. No one should be going backwards. We should be building upon what we have, using those systems. So maybe testing for SARS-CoV-2 goes down, but let's fill that space with testing for other things. And let's just be better prepared. There's no, people used to say, peacetime. They used to call inter-pandemic periods or inter-epidemic periods peacetime. There's no peacetime. You know, pandemic preparedness is a constant, and it requires constant investment and attention. The public doesn't have to worry about this all the time, and I hope we can take that worry away. But the agencies that are dealing with this need to be properly funded to be able to make sure that the world is in a better place, and governments have a responsibility to do that as well.
Can we end the COVID-19 global emergency this year?
We can. I think we can. It'll take a lot of hard work. It will take a lot of really tough questions about making sure that we address the inequity that exists. There's no reason why we couldn't. The only hesitation that I have is about the virus, is about SARS-CoV-2 and whether or not we will see different variants. We have to remain humble to this virus. I think I am hopeful that we can, because we actually have so many tools. In the beginning of this pandemic, there was no guarantee that we would have a vaccine. And now we have so many safe and effective vaccines. We really need to use those. We have treatments, we have tests, we have a workforce and a willingness. We just really need to bring that solidarity together across the world to save people's lives. And there's no reason why we couldn't do that.
Well, thank you so much, Dr. Kerkhove, for really joining us today and all of these insights. Please stay tuned for more of our panels.